بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this lecture was not ready at the time of presenting the abdominal imaging, and now it can be presented. It will deal with imaging of the kidneys, and this is a very long subject. It will be divided into two parts, and I will handle some of the topics in the first part, then I go to the other topic in the second part, inshallah. As you all know that there are a lot of imaging modalities for evaluation of the renal tract, and these modalities include the conventional radiography, the ultrasound, the CT, and MRI. And now we have also the angiographic techniques, which are usually performed by CT and MRI, and many of the interventional techniques that can help in diagnosis and therapy. And there is a persistent role for the radionuclide imaging in the evaluation of the urinary tract. Then I will try to show some of the diagnostic values of the different imaging modalities and how can we use these modalities selectively for evaluation of particular lesions. We start by the plain film, which is famously known as the plain UT or KUB, kidney, ureter, bladder. This is a very simple procedure. Sometimes it requires a preparation of the patient, such as to have a light meal at the night of the exam, and simple use of a single tablet of laxative. Then he may conduct this examination. The diagnostic value of the plain UT are many, and they include the detection of radiopaque calculi, the detection of calcification along the course of the urinary tract, also assessment of the gas pattern in the abdomen for any intestinal abnormality. It can also show some enlargement of the organs in the abdomen, particularly the liver and the spleen. And many times you can see bony abnormality, which contributes to the patient complaint. Then the famous exam also, which is the intravenous urography, which is performed after injection of intravenous contrast material. This examination requires the patient to fast for about 4 to 6 hours with insurance of good hydration, and it's better to have adequate bowel preparation, usually obtained by a light meal in the night and laxatives in the night also, and you may fast after that, and sometimes a cleansing enema may be required to adequately prepare the colon. Then before injecting contrast media, which are usually excreted by the kidney, you should have an information about the renal function, particularly the serum creatinine level. Normally the serum creatinine level is about 1, but we may inject the patient with contrast up to creatinine at the level of 3, provided that you are using non-ionic contrast medium. And this is not a rule. Many prefer not to inject the patient with contrast if the serum creatinine level is above 2. but it depends on the site and the country which perform this examination. The non-ionic contrast media are more better, of course, and they are less harmful to the kidney compared to the ionic contrast media. Then the difference between both actually in the composition of the contrast medium and also in the price, because the ionic contrast media are usually cheaper than the non-ionic contrast media, and also the reaction or the sensitivity to the contrast is somewhat low in the non-ionic contrast media compared to that for the ionic contrast media. Then what are the values of intravenous urography? They show the renal function, and you can see the excretion by both kidneys and the concentration. And one may say, I can have an idea about the renal function by laboratory evaluation. But you know that one kidney can produce normal laboratory functions of the kidney, while the other kidney is not working at all. And then you need this examination to show the function of both kidneys. And it's helpful to detect urinary tract obstruction, whether by stones or by tumors or polyps. It's good for the evaluation of the renal and the bladder masses, as I will mention, and it's very good for detection of congenital anomalies of the urinary tract, particularly the kidneys and the ureters. Then there are two obstacles against injection of patient with contrast, and they are the presence of poor renal function, serum creatinine above 3, and there is major hypersensitivity to contrast media, and these are two factors preventing the patient to be injected by contrast. Then before injection of contrast material, we should have a plain film for the whole urinary tract showing the kidneys, the course of the ureter, and the site of the urinary bladder. Then after injection of contrast, we have serial films, and the timing differs greatly between the centers, and our aim is to show the pelvic ileal system, the course of the ureter on both sides, and the urinary bladder. Then you may select the timing, the proper timing you want, and this is just an example. We have film after 10 minutes from contrast injection and 20 minutes from contrast injection. Then you may use the tomographic facility in the machine to remove the gas shadows from the renal area, so that you are able to see the accurate contour of the kidney, to evaluate the renal parenchymal thickness, and to show clearly the pelvic ileal system. After filling the urinary bladder with the excreted contrast media and urine, we have a film for the urinary bladder whenever it is full, and then we ask the patient to go to void. Then we have another film to show the ability of the bladder to evacuate. This is also another examination which is known as cystourethropy, and this examination is performed by putting the tip of the catheter at the tip of the urethra, and we inject the contrast media. We usually follow the injection under screen control until we opacify the urethral segments, and we have films. Then we may continue injection of contrast to fill the bladder, and after that we may ask the patient to void on the radiography table and to show the micturating urethrogram. And this examination is frequently known as ascending and micturating cystourethropy. This examination is very good for evaluation of urethral lesions and also for the detection of vesiculoreteric reflux. And in the previous days before MRI, it was used to evaluate patients, especially the females, having stress incontinence. But you know that MRI of the pelvic floor is now replacing this technique. Ultrasound is an old and recent imaging modality. It has a major role in evaluation of the urinary system over many years. And ultrasound is a non-invasive tool. It is reliable, it is relatively of low cost, do not use ionizing radiation, and can go to the patient bed. And then if you want to examine the patient with ultrasound, there may be some need to fast to remove some of the unnecessary gases in the abdomen, and you do not use contrast material similar to the CT or IVB, and there are no radiation hazards, as you all know. This is the normal appearance of the kidney with the renal parenchyma and the renal sinus fat, as you can see. And the values of ultrasound are too many. Number one, it can show the renal parenchymal changes. Regarding the echogenicity of the renal parenchyma, the sonographers usually divide renal parenchymal disease into grade 1, grade 2, and grade 3 renal parenchymal disease according to the echogenicity of the renal parenchyma compared to the adjacent liver and spleen. And detection of urinary tract calculi, especially in the kidney and in the urinary bladder. And this is a good example of a big calculus occupying the renal pelvis, and you see the characteristic posterior acoustic shadowing, which is the most helpful sign for calculi anywhere in the body. Then detection of hydronephrosis is easy by ultrasound. Detection of renal and bladder masses can also be conducted by ultrasound. Differentiation between cystic and solid masses along the urinary tract, detection of congenital anomalies, and the use of Doppler evaluation for the renal vessels and the vascularity of some of the masses before having a guided biopsy, for example. Then we came to the CT, which has a major role in evaluation of the urinary tract as well. But CT should be considered with care because of the ionizing radiation and the frequent need for injection of the patient with contrast media. There should be good bowel preparation sometimes in special situations, and you may use contrast media, as I will mention, and you consider the radiation hazards whenever you are repeating this exam. And whenever you are going to inject the patient with contrast, you need the patient to fast from 4 to 6 hours. And when the multi-detector CT or the multi-slice CT is now available in the market, we have achieved too many benefits. And you may remember that we are able to have very rapid scanning to assess the vascular structures in the body, and to have the vertical reconstructed images, and also to have the ability for virtual endoscopic evaluation of some parts of the body. Then we have 4 studies that can be performed by CT. The first one is known as CT-UT, which is a simple examination of the urinary tract by CT without preparation, without the need to inject the contrast media, looking only for urinary tract calculi. Then the next examination is the CT of the urinary system performed after contrast injection. Then you have the third study, which is CT urography, and the fourth study, which is CT renal angiography. The CT UT in particular is very helpful in detection of urinary tract calculi that could not be detected by plain UT and ultrasound. It also of value in assessment of urinary tract obstruction and in the detection of renal and bladder masses, and in the differentiation between cystic and solid lesions, and also to show the congenital anomalies using the CT urography facility, and to assess the renal vascularity and the renal vessels using the facility of CT renal angiography. CT of the urinary tract, or CT UT, is performed by obtaining sections every 3 millimeter scan intervals, starting from the upper bowl of the kidneys and ending by the end of the urinary bladder. These scans are obtained without the need to prepare the patient, without the need to inject contrast media. Then you look carefully at the renal area on both sides, looking for dense calculi, and whenever you finish the kidneys, you look along the course of the ureter until you reach the end of the urinary bladder. Sometimes you are confronted by a small radiopaque shadow here, and you think whether this is a calculus in the distal part of the ureter or it is a pelvic phlebolith. So these two images are very important, which are performed by the technician. He should obtain the coronal reconstructed images for the urinary tract along the course of the ureter. Then you can see the right ureter along its whole course, and you see the left ureter along its whole course. Then there are no radiopaque calculi along the ureteric course. Then this shadow should represent a pelvic phlebolith. But if you look here and you see a radiopaque shadow which is intimately related to the bladder exactly at the site of the vesico-ureteric junction. But to be sure, you should have this reconstructed image along the course of the ureter. Then you are able to see the whole ureter, and you see the calculus at its terminal part with some degree of back pressure changes on the kidney. The CT examination performed after injection of contrast media should be preceded by pre-contrast scans for the renal areas. Then you have a CT of the kidney before injecting contrast media. Then you have CT of the kidney, the ureter, and the renal bladder after injection of contrast media. After the availability of multi-detector CT, we thought to perform a triphasic study for the kidney. And then you inject contrast media, then you got what is known as the corticomedullary phase, showing the cortex differentiated from the medulla. Then you got to the nephrographic phase, where the kidney, the medulla, and the cortex are not differentiated because they are stained by the excreted contrast. Then the third phase is the excretory phase, where you can see the pelvic-calyceal system. But actually this triphasic study was not accepted as much as the triphasic study for the liver, for example. It may help sometimes, but it can lead to some mistakes in other times. Also, one of the valuable techniques is to reconstruct the images in the sagittal and the coronal plane, and to subtract the images to perform CT urography and the CT renal angiography. And this is what we call the CT urography. You reconstruct the images after injection of contrast, then you remove undesired anatomic structures. You are left by the kidney, the pelvic-calyceal system, the ureter, and the urinary bladder. And you may display this in color, and you should remember that the colored 3D images are of little diagnostic value everywhere in the body except in the face. Then before the era of CT angiography and MR angiography, we used to do this technique, which is known as flush aortography, by introducing a catheter via the Seldinger technique into the femoral artery, and we push the catheter upward into the aorta and put it at the level of the renal arteries, injecting contrast media to show the left and right renal arteries. But sometimes you can push the catheter into the right renal artery, then injecting contrast media to show the artery clearly, then you push the catheter in the left and do the same technique. But now you use the CT facility for performing CT renal angiography. You inject the contrast media intravenously, and then the machine will scan at the time the contrast media is in the arteries, and you got an image like this. This is the case of a horseshoe kidney, which has different blood supply, but actually you are not able to see clearly the vessels separable from other branches of the superior mesenteric artery, for example. Then by the same CT, you can remove the branches from the superior mesenteric artery and the celiac as well, and you are left by the true vascular supply for the kidney, which are 3 different branches on the left side and the 2 branches on the right side. And you may display, of course, the images in color, and you may have the spine, or you may subtract the spine, as you know. Then we came to the MRI, and MRI may perform both functional and morphologic imaging. It may need some fasting. If you are going to inject contrast media, there is no need for bowel preparation, and there is no hazard of radiation. And this is the MRI T1 weighted image of the kidney, and this is the appearance of the kidney in the T2 weighted image. After injecting contrast media, you may have the triphasic study showing the corticomedullary phase and the nephrographic phase, as well as the excretory phase, or you may simply inject contrast media and it will have the combined nephrographic and excretory phase. For MR examination, we should have the T1 weighted image, the T2 weighted image, and we have post contrast images. Then there is see a cyst in the kidney, which is bright in the T1 and less dark in the T2, denoting the presence of some hemorrhage inside. Then MR urography is obtained without the need to inject contrast media, and you can see the pelvic ileal system, the ureter, and the urinary bladder as well. Then you know that the kidney is located in the retroperitoneum, and it measures approximately 12 centimeter in craniocaudal diameter and 6 centimeter in transverse diameter and 3 centimeter in thickness. And you have the cortex and the medulla, which are not differentiated without the injection of contrast media, particularly in the corticomedullary phase. Sometimes you got lobulated appearance of the contour of the kidney, and this is known as fetal lobulation, which is the normal variant and should be carefully differentiated from chronic pyelonephritic kidney, as I will mention after that. Then these are the items to be evaluated for the renal imaging. Number 1, the congenital anomalies, the stone disease, renal masses, renal infection, renal trauma, and some of the miscellaneous conditions. Starting by the congenital lesions, they are a lot, and they include the kidney malrotation, absence of the kidney, hypoplastic kidney, and the duplicated pelvic ileal system or ureter, ectopic kidney, horseshoe kidney, and pelvic-ureteric junction obstruction. As I have mentioned before, IVB is one of the preferred techniques for evaluation of congenital anomalies. And you may also have this by CT urography or by MR urography. And this is an example of malrotated left kidney, and this is the normal appearance of the right kidney with the pelvis facing medially, the calyces facing laterally, but there is here malrotation of the kidney. And this can be also seen by CT. This is the appearance of the normal appearance of the kidney with the pelvis facing medially, but here the pelvis is facing anteriorly on both sides, and you may see some lobulated appearance of the kidney. Then these are some of the congenital anomalies. Also, one kidney may be absent along its whole course from the renal fossa down to the pelvis, and at that time you cannot identify any renal tissue in this anatomic area, and you see that the opposite kidney is enlarged because of the compensatory hypertrophy. And this is an example. You see a small kidney on the left side, and the other kidney is big, and you can easily appreciate the cortex and the medulla of the kidney. Then whenever you see a small kidney on imaging or on intravenous urography, and you think of one of three possibilities. Number one, a congenital hypoplastic kidney. Number two, post-obstructive atrophic kidney. Number three, a chronic pyelonephritic kidney. In the congenital hypoplasia, this is just a very normal kidney, except that it is small in size. It has a cortex, it has a medulla, it has a pelvic ileal system, and it excretes contrast media adequately, comparable to the opposite one, but it is small in size. Post-obstructive atrophy, and you see the cause of obstruction, and you see dilated pelvic ileal system with atrophic renal parenchyma. While in chronic pyelonephritic kidney, you see the kidney is small with a scarred renal parenchyma, and the collecting system is on the surface of the kidney, as I will show to you. Then this is a duplicated left pelvic collecting system with two separate moiety and two separate ureters down to the level of the urinary bladder. This condition may be unilateral and maybe also bilateral. And many times when the kidney is duplicated, the upper moiety is the site of diseases, and frequently you got vesico-ureteric reflux or you get hydronephrotic kidney because the upper moiety ureter is usually entering the urinary bladder at an abnormal site. It may go into the bladder neck and maybe into the urethra, for example. Then how can you diagnose renal duplication? And the CT scan you see here, the right kidney is good, but the left kidney is hydronephrotic. Lower down, you see that the kidney is good, meaning that you have two moieties. One is hydronephrotic and one is normal. And this is the ureter of the normal kidney, and this is the ureter of the hydronephrotic kidney. Lower down in the pelvis, you see two ureters, the normal one for the lower moiety, the dilated one for the upper moiety. And this is also an example of bilateral renal duplication with hydronephrotic upper moiety on the right side. Its ureter is also considerably dilated, as you can see. Pelvic kidney is usually located against the sacral promontory, but sometimes you can see it adjacent to the renal bladder. And this is the ectopic pelvic kidney, and this is also another ectopic pelvic kidney near the sacral promontory. Sometimes the kidney crosses the midline to the opposite side, but you should know that whenever the left kidney goes to the right side, the left ureter should enter the renal bladder from its left lateral aspect. Then whenever the kidney goes to the opposite side, its ureter, its draining ureter, should go to the renal bladder from the normal side. Then here you look at the CT scans in the upper abdomen. You cannot identify the kidneys. Lower down, you see both kidneys are located in the pelvis anterior to the psoas muscle, and these are bilateral ectopic pelvic kidneys. Horseshoe kidney means that both kidneys are fused across the midline by functioning renal tissue or by fibrous tissue. This will result in malrotation of the pelvic ileal system, giving the typical appearance of flower vase configuration. The ureters are usually normal, and they enter the bladder at a normal location. And you can diagnose horseshoe kidney by CT. This is the connection of both moieties across the midline, and this is the reconstructed image showing the vascular supply for each moiety. And this is also a reconstructed CT image showing the venous drainage, the left renal vein and the right renal vein. Horseshoe kidney, as I have mentioned, is the fusion of both kidneys across the midline by functioning renal tissue or by scar, resulting in the typical flower vase configuration of the collecting system, which is usually malrotated. Congenital pelvic junction obstruction is a neuromuscular incoordination between the pelvis and the ureter, and this will result that the urine is not smoothly evacuated into the ureter. There is some obstacle against the evacuation of the kidney. This will result in distension of the renal pelvis, then distension of the calyces, and if this condition is not treated, the kidney will lose the function. Then we have some degrees for the congenital pelvic junction obstruction: the mild, the moderate, and the severe. In the mild degree, you see some distension of the renal pelvis with preserved calyceal cupping. In the moderate degree, the distension of the pelvis is more and the calyceal cupping is lost. In the severe degree, the renal pelvis is ballooned and the calyces are ballooned as well. Then this is an advanced or severe degree of pelvic calyceal junction obstruction obtained by CT urography. You see ballooning of the renal pelvis and ballooning of the calyces. There are too many radiopaque calculi here and there, but this kidney, the pelvic calyceal system is normal. You can diagnose congenital pelvic junction obstruction by CTUT without the need to inject contrast medium. And here you see that the renal pelvis is ballooned, and the calyces are also ballooned, and you should, if you can, see that the ureter is of normal course and caliber. Then we came to the stone disease, and we have the radiopaque calculi and the radiolucent calculi. Radiopaque calculi are seen by planitie usually if they are sizable, and this is a small stone in the lower bowl of the left kidney, and this is what we call the staghorn calculus in the left kidney. And this is an example of multiple calculi in the region of the urinary bladder. And the radiolucent stones were frequently detected by IVB or by ultrasound, and you see here a large radiolucent calculus appearing as a filling defect occupying the renal pelvis and the lower ball major calyx. And you can appreciate that there is no back pressure changes, and sometimes you can see this finding. Then, if you are going to examine a patient with renal colic by intravenous urography, I advise you not to inject the patient with contrast during the colic attack. At that time, the kidney is not able to excrete contrast medium, and you will got what is known as obstructive nephrogram or persistent nephrogram. And here you see the kidney is not able to excrete contrast media enough to show the pelvic ileal system and the ureter, but the opposite kidney is good. And sometimes you may wait for some time until the kidney is able to excrete contrast media. In this particular example, you see a very small stone at the terminal part of the right ureter with persistent nephrogram, and if you wait for some time, you see the excretion of contrast within the distended pelvic ileal system as well as the ureter. But at that time, you are not able to see the stone because it will be masked by the filled bladder or the distended urinary bladder. One of the ways is to evacuate the bladder and to look once more for the calculus itself. And ultrasound is also a good tool for detection of renal calculi and calculi in the terminal part of the ureter, like this. And you see this calculus in the terminal part of the ureter. This is the urinary bladder, and this is the dilated ureter, and the dilated ureter as well as the pelvic ileal system. But calculi along the ureteric course are usually difficult to be detected by ultrasound. If you look here and you see two radio-opaque shadows on the left side of the pelvis in a female patient having left renal colic, then you want to know if these are philipoli or calculi, and you inject contrast media. Then you see that this particular shadow is located here inside the distal part of the ureter with proximal contrast stasis and normal caliber of the ureter beyond the site of the stone. And sometimes you are confronted by this after doing an intravenous urography, and you see one kidney is good, the ureter is of normal caliber. In the opposite kidney, you see distension of the pelvic ileal system and the distension of the whole course of the ureter. Usually, the ureteric course is displayed as segments because of the peristalsis. You see the segment do not contain contrast, and here you can see contrast, and there you do not, and then you see. But if you can detect contrast media along the whole course of the ureter, especially if the ureter is distended like this one, and you think of one of three: either the presence of a stone at the terminal part of the ureter, or the presence of a stricture, or the presence of the vesico-ureteric reflux. And in this case, the CT-UT is helpful, and it can show the calculus if there is a calculus, and the reconstructed image better displays the course of the ureter as well as the site of the stone. Then you should remember that the coronal reconstructed images are essential images in the examination of CT-UT because they facilitate for the radiologist the detection of ureteric calculi. And this is an example of distal ureteric calculus with proximal back pressure effect, and this is a proximal ureteric calculus with distension of the renal valves. And this is a CT scan of a patient with flank pain on the right side and fever. And here you see that there is a radio-opaque calculus at the terminal part of the ureter. There is distension of the renal pelvis, and inability of the kidney to excrete contrast media. You should know that this is not contrast because the renal pelvis does not contain contrast material, as you can see here. Then CTUT once more is helpful in detection of renal calculi, which are easy to be detected without the need for coronary reconstructed images. But for detection of ureteric calculi, you should have these images which display the whole course of the ureter more better than the axial images. And this is a stone or a radiopaque shadow on the right side of the pelvis. And by CT urography, after injection of contrast media, you can see the site of the calculus and the proximal back pressure effect on the renal pelvis and the calyces. And also on the left side, you can see the duplication of the pelvic calyceal system. Then we came to the major issue, which is the evaluation of renal masses. And you see a lot of lesions. Actually, we will not discuss all these lesions in the first part of the lecture, and I will tackle only the simple renal cyst and the atypical renal cyst, the polycystic disease, infantile and adult, as well as the renal sinus cyst, and I will leave the remaining issues starting from the renal cell carcinoma for the second part of this lecture. Then starting by the renal masses, you know we have two main kinds of renal masses: the cystic masses, which contain fluid, and the solid masses, which contain solid material. And we are sometimes confronted by a mass which contains both components, the solid component and the cystic component. And I hope you remember that I have said too many times, if you are confronted by such a lesion, you consider it totally solid. A lesion with a cystic component and a solid component, you consider it totally solid. Then we have only two lesions, the cystic one and the solid one. Renal cysts are considered under many topics, and the simple renal cyst and the Bosniak classification, the polycystic disease, and the complicated cysts. A simple renal cyst is a very common incidental finding on imaging, on ultrasound, on CT, and previously on IVB. And they taught us that for diagnosis of simple renal cyst on intravenous urography, you can see this finding, which is a stretching and displaying of the calyces, meaning that the lesion here is benign. But ultrasound is very good to show the cyst, and also CT is very good to show the cysts, which may be multiple and bilateral. Then the simple renal cyst is a very common entity, and the cause is unknown. And you remember the typical cystic criteria, which are 7: 3 positive and 4 negative. The 3 positive are the smooth, sharp margin, paper thin wall, and clear water content. And the negatives are no septation, no calcification, no mural nodules, and no enhancement, no contrast enhancement. These are the criteria of the simple renal cyst, or the simple cyst anywhere in the body. This is the ultrasound appearance of a simple renal cyst with acoustic enhancement, posterior acoustic enhancement, which is typical. Simple renal cyst by CT, fluid containing lesion; by MRI, low signal in the T1 and high signal in the T2 weighted images. The Bosniak classification of the renal cysts include 4 categories for the simple for the renal cysts. Category number 1 is the simple renal cyst with the previously mentioned 7 criteria: a cystic lesion with paper thin wall, clear water content, and sharp, well-defined margin with no evidence of septation, no calcification, no mural nodules, and no enhancement. Then category number 2 In this cyst you may find 2 or 3 very small internal septations, and this is considered the category number 2. Under the same category, you may see a small cyst less than 3 centimeter, but it has a high density or a high attenuation value, like this one. And you see in the pre-contrast study, the cyst is dense, and in the post-contrast study, it will appear hypodense because it is compared to the enhancing renal parenchyma, and this is category number 2, provided that the cyst is smaller than 3 centimeter. And this is an example of hyperdense cyst, category number 2, a small cyst with hyperdense contents in the pre-contrast scans. In category 2F includes that the cyst will contain more septations and may contain calcium. Then the cyst have sharp margin and there is no enhancing soft tissue component. This is known as category 2F, big cyst with calcium or big cyst with internal septations. The septations contain calcium. Under the same category, the cyst, the high attenuation cyst, which is more than 3 centimeter in diameter. And this is the category 1, simple renal cyst. This is category 2F, simple renal cyst with internal septations and calcifications. And this is the remaining images of the same cyst. You see internal septations too many with mural calcification in the outer wall of the cyst as well as in the septations. Category number 3, there are more internal septations and they are thick and they are enhancing. So if you see a lesion like this and you see cystic lesion, internal septations that are thicker and enhancing, and this is category number 3. Category number 3 usually prove after histopathology to be this lesion, which is known as multilocular cystic nephroma. I will mention this in the second part of the talk, but this is considered a benign lesion, and you see internal septations, and the septations are many and they are enhancing. But this cyst actually contains some septations, and septations are very thick, mounting to the formation of a solid component. Then a solid component in a cyst, meaning that it is totally solid, and it will go to the category number 4, which is the cystic renal cell carcinoma. And this is category number 4. You see a cystic lesion with a very thick margin and a solid mural nodule. This is category number 4, or cystic renal cell carcinoma. What are the causes that lead to increased density inside the cyst? Either the cyst may contain hemorrhage, or secondary infected with the resultant of pus inside the cyst, or the contrast may leak in the cyst itself, or there may be some calcification. This is actually a calyceal diverticulum, and you see the connection of the lesion to the pelvic calyceal system with simultaneous opacification with the excreted contrast as well as the collecting system. The renal sinus cysts are different from the previously mentioned cysts, and they are usually located at the renal hilum, displaying the calyces. These cysts may be unilateral or maybe bilateral, but they are better evaluated in the excretory phase when you are able to see the pelvis and the calyces. In the corticomedullary phase, you may think that this cyst may represent dilated renal pelvis, but in the excretory phase, you see that the calyces are pushed and compressed by this cystic lesion, which do not contain any of the excreted contrast media, denoting that it is a renal sinus cyst or a parapelvic cyst. And whenever the cyst is secondary infected, then you got renal abscess. and in the abscess will show a thick enhancing margin with a stranding of the perinephric fat. And this is for the diagnosis of renal abscess. And you see what looks like a cyst, but with a thick enhancing margin and a stranding of the perinephric fat. Sometimes you got air inside the renal abscess, as I will mention after that. Then we came to the polycystic disease, and we have two types: the autosomal recessive infantile polycystic disease, and this is the incidence, or the adult autosomal dominant polycystic disease of the kidney. And this will result in too many small cysts in the kidney, giving the kidney a sponge-like appearance. And we have four forms of the disease: the antenatal form, where 90% of the tubules will show cystic changes; the neonatal form, where about 60% of the tubules will show cystic changes; the infantile form, where 20% of the renal tubules are involved, and the presentation will be in the range of 3 to 6 months of life; the juvenile form, which is the milder form, 10% of the tubules are involved. The presentation is usually seen around the age of 1 to 5 years. The imaging findings are: the kidneys are very large. The kidneys are replaced by many small cysts ranging in few millimeters in diameter. The renal function is poor, and this is usually occur after birth. In both cystic renal diseases, the infantile type and the adult type, other cysts are usually located in the liver, in the spleen, and sometimes in the pancreas. And this is an infantile type of polycystic kidney. The kidneys are huge. They are replaced by so many numerous cysts, giving the appearance of a sponge-like kidney. There is loss of the corticomedullary differentiation. There is poor visualization of the renal sinus fat, and the collecting system may contain some of the contrast material according to the remaining functioning tubules. Then this is also an infantile polycystic kidney, and you see the kidneys are large and replaced by too many cysts with few foci of calcification seen bilaterally. MRI coronal T2 weighted image showing bilateral infantile polycystic kidney and variable sized high attenuation cysts seen almost totally replacing both kidneys. And this is another case. In the T1 and T2 weighted images, the kidneys are replaced by fine cysts of low signal in the T1 and high signal in the T2 weighted image. Then the autosomal dominant polycystic kidney disease is this disease is a slowly progressive disease with a positive family history in almost the major part of the cases. And this is the incidence is about 1 per 1,000, and the is considered the third most prevalent cause of chronic renal failure. The mean age of diagnosis and presentation is about the 40 years of age. In this particular disease, you see that the kidneys are enlarged, and they are containing too many variable sized cysts, but the renal function is somewhat preserved, and you got some excretion of contrast by the kidney, and you may be able to see the pelvic-calyceal system. But renal failure and hypertension usually develop by the fourth decade, and as in the infantile type, you also see hepatic, splenic, and pancreatic cysts. Then here you see a coronal CT reconstructed image of an adult type polycystic kidney disease with many renal cysts affecting the parenchyma bilaterally, but you are still able to see some functioning renal tissue on both sides. Then the onset of cyst formation, this is the incidence, about 54% in the first decade, 72% in the second decade, and 86% in the third decade. These are common associations with the polycystic disease, as cysts in the liver and in the pancreas, and also the association of cerebral aneurysms, which are the cause of many complications and hazards, also mitral valve prolapse, of course hypertension, hematuria, proteinuria, and abdominal pain. Then this is an example of a bilateral polycystic kidney disease, adult type, many cysts affecting both kidneys as well as the liver, and there may be some calcium in the cyst wall or in the renal parenchyma. Polycystic kidneys may shrink after beginning of the renal failure, or after a renal transplant, or on chronic hemodialysis. The complications of adult type polycystic kidney disease include death from uremia and death from cerebral hemorrhage. You remember the cerebral aneurysms, cardiac complications, then the frequent detection of renal calculi, and the increased frequency of renal infection, the cyst rupture and the hemorrhage, and as well as the increased risk of the development of renal cell carcinoma. And the differential diagnosis of adult type polycystic kidney disease include multiple simple renal cysts, and the cysts are less diffuse, they are few in number, and there is no positive family history for polycystic kidney disease. Von Hippel-Lindau syndrome, there are usually cerebellar hemangioblastoma or spinal cord hemangioblastoma, and positive family history for von Hippel-Lindau syndrome. The acquired uremic cystic disease, or the polycystic disease related to the dialysis, the kidneys are very small and the renal function is poor or no renal function, and you may also see the transplanted kidney in the iliac fossa. Then infantile polycystic kidney disease, the cysts are usually microscopic and there is no functioning renal parenchyma. Then if you are confronted by a case of multiple bilateral cystic lesions in absence of positive family history for polycystic kidney disease, then there are at least two of the following criteria will support your diagnosis of autosomal dominant polycystic kidney disease. Number one is bilateral enlargement of the kidneys. Number two is the detection of 3 or more cysts in the liver, as you can see here, or the detection of an intracranial aneurysm, or the detection of pineal, arachnoid, pancreatic, or splenic cysts. This is an example of adult type polycystic kidney disease with numerous hepatic cysts as well. This is what I meant by which is multiple bilateral simple renal cysts. Sometimes normal people do not contain from any urinary tract abnormalities, and on imaging you can detect some renal cysts bilaterally, 2 or 3 or 4, but the renal size is normal and the renal function is good, the renal parenchymal thickness is maintained, there is no family history, and there is no hypertension or renal failure, and there is good renal parenchymal thickness, as I have mentioned. هذا وبالله التوفيق والحمد لله رب العالمين.